I'd like to thank Avita Medical for the opportunity to talk about RECELL. I am Derek Bell. I'm a professor in the Division of Plastic Surgery, as well as a professor in the Department of Orthopedic Surgery at the University of Rochester Medical Center. I'm the Kessler Burn Director, and I've served in this role for the past 15 years. I have a unique role in that I'm both a plastic surgeon as well as a burn surgeon. I take care of all of our burn patients and have an extremely busy plastic surgery practice as well. My practice consists primarily of soft tissue injuries, a lot of cancer, and reconstructive needs. I started using RECELL approximately 4 years ago, and I can tell you that using this technology has revolutionized not only how I take care of my burn patients, but as well as my plastic surgery patients. And as I've spoken in the past, I wish I had this technology 15 years ago. Again, I'd like to thank Avita Medical for the opportunity to discuss the product as well as share some of my patient experiences with you today. In terms of disclosures, this is the only company I speak for. The RECELL system is extremely innovative. This was developed by Dr. Fiona Wood, who is a plastic surgeon in Australia and also a burn surgeon in Australia. She's designed these technologies to repopulate the skin surfaces in patients with both soft tissue injury as well as burn injuries. With this technology and having discussions with her in the past, I've had the fortunate opportunity of having dinner with her on several occasions. This was initially developed after they were utilizing cultured epidermal autografts, which take a long period of time to grow. In a laboratory, they take about 18 to 21 days. And from a burn standpoint, all that while we have a patient that has an open wound, and the number one cause of mortality in these patients is infection. So they really push the envelope with culturing these cells earlier and earlier to the point in time where she said to me that she's like, why do we have to grow them in a petri dish? Why do we have to grow these cells in a lab and then transfer a sheet of cells onto the patient? Maybe we can just put the cells on the patient and then they can grow on the patient's wound bed. So this is how this came to fruition. So with this, we obtain a skin sample. We enzymatically and mechanically degrade the skin sample into individual keratinocytes, and then we apply the skin graft in an aerosolized form. With this, there's an 81 expansion ratio. So every square centimeter that we harvest a skin cell from is expanded 80-fold. I take care of a lot of soft tissue injuries. This is one of my more recent patients where we were attempting skin salvage. This is a 44-year-old female who came in with a necrotizing infection to the left lower extremity. And this is her picture at her initial presentation. Here she is, hospital day 2, when she was taken to the operating room, at which time they involved me in her care. And I told the trauma team that her lower leg is not salvageable, and I was extremely concerned that this one was going to die from this infection. So they amputated above the knee. Here she is, hospital day 3 after takedown. You can see that she has ongoing progressive necrosis of the posterior aspect of the left leg, which needs further debridement. So things that I'm taking into consideration when I look at this patient is that she has a very convoluted wound bed, as you can see from the undulations of the subdermal fat along the medial aspect of the leg. She's diabetic. She's super morbidly obese. She's an enormous woman. She's a former smoker, and that she smoked until the point that she came into the hospital. And also when I look at these patients, I take into consideration potential pitfalls of why a graft will fail. And given her body habitus and now her immobile status, given that she has one leg and she's super morbidly obese, I'm concerned that she's going to be at risk of graft shear. So these are all things I'm thinking about when I evaluate this type of patient. After the trauma team was done with their debridement processes and she was stabilized, I took over her care. I employ the usage of a wound vac pretty liberally on a lot of my patients. I think it's nice in pulling away the fluid, helping with edema control, as well as stabilizing the soft tissues and helping with rapid granulation of the wound beds and optimizing the wound beds. I think really optimizing the wound beds is critical for success of both skin grafts as well as using RECELL. In this patient, I used an allograft first to stabilize the wound bed, as well as giving me some insight as to any potential areas where we may have graft failure. So the allograft took very well. You can see here it is 5 days later. And again, to give you guys some perspective as to the size of this woman's legs, you can see the hands on her proximal thigh. Her legs are quite robust. So here she is the day that I'm going to apply RECELL on this patient. I look at the patient, I look at the wound, and I first look at the wound that I have to contend with, and then try to figure out what I have for donor sites. So with her, really the best donor site is the opposite leg. So here's her anterior and posterior leg where she had the necrotizing fasciitis. And this is just before her debridement. And here she is 7 days following RECELL application. So you can see that she has excellent graft take, and the interstices between the widely meshed graft are healing in extremely well. The area along the anterior thigh, actually, that looks a little suspect, but that's actually clot that's on top of the grafted area, as well as along the perimeter of the posterior aspect of the leg. But she's healing extremely well. And here she is 14 days later. She has a tiny little area about the size of a quarter along the anterior thigh that I put some Aquacell on, but the rest of it's entirely rekeratinized, and she's at moisturizer stage, and she's ready to go to rehab. And she required no additional procedures from me. So after debridement and application of a definitive graft, she's one and done, 14 days, moisturizer. We're not being held up with ongoing needs for wound care. They're predisposing her discharge from the hospital. So again, what is this system? So what we do is we harvest a split thickness skin graft. Usually I take it from the thigh. The recommendation is to take it between 6 and 8 1/1000ths of an inch. I usually take it around 7 1/1000ths of an inch. So we take a small skin graft. You put it in the RECELL system in the well that you see at the top left in that picture. And then with that, it both mechanically and enzymatically breaks down the skin into keratinocytes and melanocytes. So again, enzymatic degradation takes about 15 to 20 minutes. With a new system that will be coming out, it's all automated. And here you can see I'm operating very fast. This is sped up. But you can see it's pretty straightforward. I pin down the skin graft and then use the belly of a template scalpel to mechanically disaggregate the cells. And then they go into this a buffer, and then you can see the C well there, the yellow well. That's got a very fine mesh filter on it, so you get a residual dermis out of the suspension, so it doesn't clog the system. And also you can know that you're applying keratinocytes. And then you spray it on. This is one of my friends, Jeff Carter, down at LSU, applying it to a leg. And it's pretty straightforward. I have the residents and medical students do this. You can see what's surrounding is Telfa Clear, so that helps to capture the cells and hold them against the wound bed. But even if you don't use that, the keratinocytes will stick to the exposed collagen. But the application process is pretty simple. And there he's applying the Telfa Clear. So the dressings are pretty straightforward. Telfa Clear goes on the outside. A Vaseline type gauze thereafter. I like to use Euroform. It comes in huge rolls, so I can cover huge surface areas rather quickly. Then an outer gauze. I use Curlex or burn gauzes that come in sheets, and then usually Coban or an Ace Wrap. So the dressings are pretty straightforward. So it stays in place for 7 days, and we take it down at 7 days. RECELL is nice in that there are 3 RCTs, randomized control trials, that look at its efficacy. First, this was utilized in looking at partial thickness burns, with comparison of 2-to-1 skin graft versus RECELL. There was a study that was looking at mixed depth burns, again, a comparison of skin graft alone, which is the standard of care, versus RECELL and more widely meshed skin graft. And more recently, unfortunately, I was involved in this study looking at full thickness skin graft defects, again, utilizing RECELL versus the standard of care with a mesh graft. So what they did is they upsized the graft ratio by 1 and looked at its efficacy in covering these grafts. There's a recent study looking at vitiligo, which has been submitted for publication as well. So this is a great product, and it has 3 published RCTs. I think that RECELL is nice in that it's an adjunct to our armamentarium, and it's something that we can employ that fits along our reconstructive ladder. So knowing how to manage wounds, we look at primary closure, secondary closure, ADMs, which I use a lot. The most challenging and laborious to close wounds are free flaps. But this kind of fits along the line of our split thickness skin grafts and utilizing the RECELL itself. So this is an adjunct to our reconstructive ladder. So normal wound healing by secondary intention versus split thickness skin graft versus a full thickness wound with a split thickness skin graft that's widely meshed, and application of the RECELL. So what is in the suspension? So looking at this histologically, the vast majority of the cells that are in this suspension are keratinocytes, but there are also percentages of melanocytes as well as fibroblasts. Some people have asked me when I've given this talk before, my experience utilizing this in patients with darker skin, and this works fabulously in filling in the interstices so they don't have this perpetual meshed appearance of the skin. It's great at blending the skin, and in patients I've utilized just widely meshed grafts in the past, they have areas of hypopigmentation, and that persists, and it looks like their grafts look like a chain link fence. It looks terrible. And the first child that I used this in was a baby that had 3rd-degree burns on the entirety of his back, and this baby was like 4 months old. And I meshed a graft from his thigh. Granted, this kid has little chunky thighs, and did a widely meshed graft 4-to-1 and did RECELL, and everything blended fabulously. You can't even tell that this kid has a skin graft on his back. I love this slide. So on a histologic level, what are the keratinocytes doing? So you can see on the edges of this cross section where the areas of split thickness skin graft are, and how this correlates with the yellow circle that you see on this porcine model. So those are the split thickness skin grafts. Are widely meshed, and you can see that the interstices between the two have re-epithelialized in 3 days in this porcine model. So I think this is a really, really powerful slide in demonstrating that you do have rapid re-epithelialization between the interstices. Prior to its usage in my hands in a widely meshed graft, I would often have struggles with these areas becoming kind of quilted, if you will, with the areas of granulation tissue between the mesh graft, which would take a very, very long time to heal in, and not heal in very well. The persistence of that quilted appearance would often exist for many months and require compression garment therapy. This is much less of a necessity in my patients when utilizing RECELL. So this is my first RECELL patient. So this is a 21-year-old female who had second and third degree, deep second and third degree burns to the bilateral lower extremities. She was a 12% body surface area burn. She was hanging out with friends, and they decided to throw shocks from a car into the fire, which generated the explosion that I think they were probably anticipating. But in doing so, they harmed their friend here. So when I look at this individual, and here she is a couple days after her injury, there are things I take into consideration. Again, what are the wounds I'm dealing with? How do I get them covered? How do I do so expeditiously? But also, being a plastic surgeon, I want to take into consideration not only the areas that I have to cover, but also the donor sites as well. So again, young female, 21. You can see that she tans very easily. I want her legs to look nice, and she's also very heavily tattooed. So this kind of limits my donor site options because I do not want to transpose a tattooed area onto her legs. So here she is on the day that I took her to the operating room. You can see the donor site on the left side, or on the right side, excuse me, where I take the skin grafts extremely thin. I take them about 4/1000ths of an inch for the autologous grafts. Again, I took an area proximal to that for the RECELL. But again, I'm dancing around the tattoos that she has on her thighs. So with this graft, I took one graft, meshed it 4:1, cut it in half. And you can see on the photograph on the left, there's actually a seam through the middle there. That's if you look closely, you can see the seam between the two. So I took the graft, cut it in half, and put them end to end so I could cover the entirety of the length of her leg there. So again, here she is at admission. Shortly thereafter, she's out of the hospital. After I reselled her, she's out of the hospital. This patient would have been in the hospital for weeks previously. Here she is post-op day 39 in the office. I'm still a little suspect. You can kind of see the meshed appearance a little bit on the right lateral calf region, but overall she's looking pretty good. And here she is at 6 months. I think the picture speaks for itself. Again, she likes the sun. She gets tanned pretty easily, and you can't tell that she was even grafted. And again, with the composition of what is in the RECELL, we've transposed melanocytes onto her legs, so she has capacity to obtain a tan that blends nicely with the areas that are not injured. So I think this is a really powerful set of photographs in my first patient. So with this, I was sold. My first patient that I applied RECELL to with facial burns is a 29-year-old gentleman. This is a couple days after his initial presentation. He was involved in an explosion type injury, and he's got deep second-degree burns and third-degree burns to his face, neck, and ears. This is a patient that previously, prior to utilizing RECELL, I would give a very long time to see what his face did in terms of reepithelialization, to the point where prior to RECELL, this patient would be in the hospital for the better part of a month. So here he is a couple days after his injury. I'm considering, maybe I have to sheet graft his neck, but I decided to RECELL everything. So here he is on the treatment day. I like to utilize the dermabrader in these patients. I think it very nicely gets rid of all the dead tissue, and it really helps me to get in all the nooks and crannies to really optimize the wound bed to ensure that there's no residual detritus in those areas. And he's out of the hospital. I sent him home the next day after I grafted him. And here he is post-op day 7 back in the office. Here he is post-op day 14. And this guy looks fabulous. He's a little bit crunchy when I took the dressings down post-op day 7, but it's just some residual dried blood and such. And I was most impressed with his neck. So this is a patient that I would have probably put a sheet graft on previously, but his neck healed in fabulously well. And the ears are always tough to contend with. I put sulfamyl on the ears for cartilaginous penetration, help mitigate chondritis or gram-negative infection. And I called up one of my friends, Nicole Capari, and I said to her, you ever RECELL an ear? She's like, no. I was like, well, I'm going to do it. We're going to see what happens, because these areas are impossible to put a sheet graft on because of all the convolutions of the ear itself. So again, I used the dermabrader to remove all that detritus. And here he is at the time I spray him. Here he is post-op day 7, and here he is post-op day 14. So this young man is entirely healed at post-op day 14. He's getting moisturizer and everything, and he's going back to work. So again, this is a young man that would have still been in the hospital, but now I'm sending him back to work. And also, I tell these patients that the last thing to heal is going to be their ears, and it's going to take months for their ears to heal, but not anymore. Not when I spray them. This is one of the patients that was involved in the soft tissue study that I referenced previously. So this was a study, multi-centered study with over 60 patients that were utilized in the study. This is my patient that had a fasciotomy site. You can see the standard of care site, which is site A, which is meshed 1-to-1, and B, which is meshed 2-to-1 with RECELL. So the picture on the right, you can see this 1 year later. There's excellent coverage. The grafted areas are soft, supple, pliable. He has no restrictions with movement of the calf muscles, and he's healing fabulously. It's another one of my patients that, in conjunction with the burn patients, I take care of a lot of soft tissue injuries. Other people don't have capacity or desire to care for. And the skin popping heroin patient population can be extremely challenging to care for. So again, I look at this young lady's legs. She's got extensive soft tissue necrosis, which is nearly circumferential from the knees to the ankles. And then I look at my donor site options. She's extremely cachectic. She's got a BMI of 16, and she doesn't really have any great donor site options. You can see from her thigh, she has extensive scarring from her heroin abuse. And what you can't really appreciate from the picture itself is these areas where she has track marks are they're very deeply convoluted. So I can't really take a graft from those areas, because the graft will shred and skip, and I won't have a great graft that will be reliable for grafting these areas. So this is a patient that is ideal for utilizing RECELL, because I can take a graft between some of those areas, which I did along the posterior thigh, again, dodging the tattoos and applying not only split thickness graft, but also the epidermal autografts to those areas. So the things I take in consideration with this patient: she's got terrible tissue quality. She's cachectic. The soft tissues are really, really densely calcified. So when I'm using the Humvee to cut through these areas, you can hear the blade crunching as it goes through the calcified tissues. And she's significantly emaciated and malnourished. I like to utilize allograft a lot in preparing my wound beds as a temporary coverage. So here she is at the time of excision. I got into the subdermal adipose tissue outside of the zone of dense calcifications, but not violating the fascia, the muscle fascia, or the periosteum. I allografted her, left the allograft on for 2 weeks. I know the wound beds are stable and reliable. And here she is at the time of definitive grafting. In this photograph on the left, again, I take my grafts very, very thin. Grafts were taken at 4/1000ths of an inch, and she has 4-to-1 mesh grafts on both legs in this area, and applied the RECELL to the interstices. In her, I used zero form Curlex and A-straps after applying the Telfa Clear. And here she is. She's out of the hospital and comes back to the office 7 days post-op, and she's healing fabulously. I think that this is really powerful. Looking at a zoomed image of this, you can see the interstices are rekeratinized. So she's a moisturizer. So she's 7 days out from really devastating wounds to bilateral legs. Not only were we able to salvage her legs, but do so in a timely manner, get her out of the hospital quickly with really great, reliable soft tissue coverage. So you can see in this photograph on the left, the 4-to-1 mesh graft and the interstices are totally rekeratinized. So you can see with this, the work RVUs from the first 100 square centimeters on the trunk, arms, and legs is 11 RVUs, with 2 RVUs for each additional 100 square centimeters. The more challenging areas, both cosmetically as well as functionally, the head, neck, hands, feet, genitalia, are 11.2 for the first 100 square centimeters, and 2.5 for each 100 square centimeters thereafter. So this is just from the delivery and the creation of the epidermal autografts. In addition to this, if you're utilizing an ADM, which I do sometimes, or utilizing a split thickness skin graft from the patients I've shown you, you can bill for the application of the split thickness skin graft, as well as the preparation of the wound bed, as well as the application of the RECELL or the epidermal autografts. For each 100 square centimeters, you can triple bill. In addition to that, Avita has secured a C code to cover the expense of the kits. The kits cost about $6,500. And utilizing the C code alone, you generate between $800 and $1,000 just from using the kit. So the kit doesn't lose money. What about hospital costs? Aside from the kit, aside from professional fees, some studies looked at the financial advantage to utilizing RECELL. So in one study, again by Jeff Carter, looking at burns less than 50%, burns, so pretty big burns, there's a 13% reduction in length of stay, which calculates at $37,000 in cost savings per patient. Most of our patients are not 50% burns, so what about the majority of the burns that we're seeing, less than 20%ers? So again, looking at this, they found a 10% reduction in length of stay. So in our facility, the length of stay is somewhere around $3,000 or $4,000. So if you can reduce the length of stay by a couple of days, you're generating tremendous cost savings for the hospital. So with these, they found that there was a $22,000 cost savings per patient. And for non-thermal full thickness wounds, we have seen similar cost savings and great clinical outcomes. So with this product, I think that's great for patient outcomes. It is the standard of care for these patients. I've given you several examples why. So most importantly, this is what's right for patients. But also in doing so, they're out of the hospital faster, and it saves our healthcare system a tremendous amount of money to free up hospital beds for new patients that need them. So in closing, RECELL uses significantly reduced donor site skin to heal a variety of skin soft tissue injuries, whether it's burns, necrotizing fasciitis, heroin avulsion injuries, etc. And there's a 30% reduction in the skin graft donor site needs. This can translate into reduced patient burden, hospital costs, and overall costs. And I can tell you that working with Avita for the past several years, they have absolutely far and away the best group of support systems and personnel that I've ever worked with. Even if I don't want the reps around, and they are a fabulous group to hang out with and work with, they show up. So they are around, and they are always ready to provide support. So it's a great team. I'm very privileged to be working with them. And of course, there's only some important safety information. So with that, I thank you for the opportunity. I thank Avita Medical for involving me, not only in the utilization of this product, but the opportunity to speak about a product that I believe in wholeheartedly. I thank you for the opportunity to discuss some patients and their fabulous outcomes. So thank you, and I hope you use RECELL.
So I'd like to thank you for reviewing some of my cases and listening to my experiences with RECELL. I will answer some questions that are popping up in the queue. Feel free to ask any questions, and I'll answer them from the queue. So question number one, compared to your pre-RECELL use, has there been a noticeable difference in the outcomes you see today? Specifically, cosmetic, pigmentation, or healing time? I alluded to a little bit in some of the patients that I presented. From a cosmetic standpoint, I think the patients heal fantastically. The grafts are flat, soft, and supple. I was recently asked about this at a talk, which you cannot delineate from from the pictures, but they do heal really soft and supple. And I don't know why that is, but I've not had a lot of problems with these patients requiring compression garment therapy. Again, I don't know why that is, and that's not just segregated between those that use an ADM and those that I don't. But very few of those patients require compression garments or even laser therapy for that matter. You can see from some of my patients as well as the first patient I talked about that I used RECELL on, a child who was black and filled in the interstices very nicely. My first patient, you can see from her photograph of the legs that you can barely tell that she was grafting. You cannot see that meshed appearance in those patients. So there are often times that I will decide to use RECELL in a patient that I have to use a mesh graft, even if it isn't a huge area where I have to mesh it widely, but I will spray those patients specifically to fill in the interstices and mitigate that dyschromia that may persist. Again, healing time. These patients are they're out of the hospital. I spray them, and as soon as they clear physical therapy, they're out of the hospital. Their postoperative pain is very, very minimal. They have some pain at the donor site, but again, there's a 30% reduction in the size of the donor site. So with that, there's a reduction in pain and ease of transferring these patients out of the hospital. And most of the time, at 7 days, these patients are very, very close to just having moisturizer at that point in time. So healing time in these patients is rapidly excelled. I don't know the actual number of days of saved by healing time, but they do heal very, very rapidly, even with the patients that are widely meshed. Another question: have you seen a large decrease in the length of stay with these patients? Yeah, I again get them out of the hospital after they are sprayed. Usually they're out of the hospital next day. Of the patients I've done this summer, I cannot recall, and I usually do a couple a week on average, one or two, maybe three a week on average, and they're almost always out of the hospital the next day because their pain is less. I'm not aware of a study that has shown their pain reduction, but we should look into that. Do you have any experience with the use of negative pressure wound therapy over RECELL treated areas? And what is your dressing protocol when negative pressure therapy is used? I use a lot of negative pressure therapy. I think it works really well in providing uniform compression at all the conformities of the skin, so that I can be assured that the skin grafts as well as the cells are held tight against the wound bed surfaces. I will use negative pressure in most of my patients. If there's a flat area where I can get uniform compression with an ACE wrap or with Coban, then I will refrain from using wound vac or any negative pressure device for that matter. Things that I do not use negative pressure therapy on are areas that are close to the eyes or the mouth. But I just did a girl today, and I put a vac across her neck and her shoulder area. Otherwise, an area that you can't really get compression on because they are dynamic. I don't like putting patients in neck immobilizers and things like that because I think that's uncomfortable for the patient and can cause graft shear. So with the vacs, I allow for the patients to mobilize and walk. I cannot recall the last time that I put a patient into a splint, into a lower extremity splint. So again, these are things that may impede the patient's discharge, but the negative pressure therapy is not one of them. Early on, I was criticized for using negative pressure therapy because there's a thought that the the vac may suck up the skin cells, but that does not happen. So what I do is I create a trilaminar construct with the Telfa-Clear, Zeroform, or whatever Vaseline gauze you may use, and then the vac itself. So it's all pre-created. I cut it before I put the grafts on, so I'm not shifting the grafts or anything like that. I put it on, and then put the vac drape on top. So I'm creating this while we're waiting for hemostasis, or while somebody is on the back table preparing the epidermal autografts. Another question. How does RECELL apply to vascular wounds after revascularization? I work very closely with our vascular colleagues. I take care of many of their wounds, many of the fasciotomy sites. It works well. I have no problems with it whatsoever. I've not had to regraft anybody that I've used RECELL on, so it works extremely well. Let's see. I'm just going to the. Can the system be used in chronic wounds? Can it be used in an outpatient setting? Hi, Majid. It's good that you're on the call. What a blast from the past. Yeah, it can be used in an outpatient setting. There are codes for that, and it works well. It works well in chronic wounds. I've started spraying venous stasis ulcers. The surgeons on the call can appreciate that this is the bane of our existence often. But I've sprayed several venous stasis ulcers, some large venous stasis ulcers, and they do very, very well. Some people have asked me about using RECELL on pressure wounds. I have not done that, but some of my colleagues have, and similarly, they don't seem to have any problems with it. I think the thing that's nice about it is, unlike a mesh graft, it can really get into all the convoluted surfaces and help with the healing in that regard. Thanks for the question, Dr. Karamati. What is a routine dressing for donor site? I will use something that's not entirely adherent. I like to use Mepilex AG if I can. The challenge with that, however, is I usually take my grafts between 3 and 4 inches in width, and the Mepilex AG is about 2 inches in width. So I have to create a side-by-side, if you will, of the Mepilex AG to put on the donor site. If it's a larger area and I don't have any keratinized skin after taking the graft to affix the Mepilex, then I will go back to the old school Zeroform. But again, we can appreciate that the Zeroform can be painful, and also after the patients start to ambulate and it starts to dry out and get crunchy, then it can be extremely painful as the patients move, and it's affixed rather tightly to their skin. All right, so the cost. So somebody just put a question mark in the cost. So the cost of utilizing the kit is somewhere around $6,700 for the kit. Again, you get paid a C code for utilizing it, which is $7,500. So you don't lose money on the cost of the kit itself. In terms of the utilization of the RECELL, it reimburses extremely well. For those of us that are acknowledged based on RVUs, does a great job with RVU reimbursement from a financial standpoint. It correlates very, very closely, and that it pays very well for those of us that are acknowledged or incentivized in those ways. So I don't see any other questions in the queue. Again, I want to thank Avita Medical for the opportunity to talk about a product and technology that has really revolutionized not only my practice and how I care for patients, but on a national and getting to be global level beyond just Australia. I think that this is going to significantly impact changing lives and saving lives with our burn patients and with our wound patients as well. So I thank you. It's really exciting to be part of this, and I thank Avita for the opportunity to talk on their behalf.